For this first exercise of phase 2 of the rehabilitation program, we will have our patient perform the 4-way ankle exercise. Since we are at home, I have the patient sitting on a couch with their leg resting on a chair and about 3-4 inches of the foot hanging off of the chair. They will then be instructed to plantar flex, dorsiflex, inversion, and eversion. Okay. Now, as a clinician, you will also want them to advise them to not compensate during this motion with any internal rotation or external rotation of the hip during inversion and eversion. You want them to do this exercise with 3 times 10 repetitions in each direction. This could also be progressed by resisting with a resistance band, by placing the resistance and a little higher. There we go. All right, there, during plantar flexion, and then going around the chair to increase the lever during eversion. The chair will have to be rotated for eversion. All right, more towards the top pivot. Right there. Okay, and under this loop to increase the lever. That's right. During dorsiflexion resistive, unfortunately we couldn't find our longer band, but this could also be done with a towel. But due to its lack in elasticity, the patient would have to allow for more give using their body a little more. Okay. For the next exercise of the phase 2 rehabilitation program, we have instructed our patient to perform towel curling exercises. We have asked our patient to sit on a couch and have placed a towel directly in front of them. And then the patient will proceed to bringing the towel in using only the toe flexors of the foot. This exercise will be performed 5 to 10 times depending on the progression of the athlete. This exercise can be progressed or made harder by adding a resistive force to the towel with a 1, 2, 3 pound weight, a water bottle of some sort. Once this athlete has performed this as required, the 5 or 10 times, we can then proceed to do this in other directions, such as inversion and eversion. Using the inverters of the foot, the patient will bring the towel in 5 to 10 times again. As a clinician, you also want to advise them to not compensate by adducting the hip during inversion or abducting the hip during eversion. For this exercise of the phase 3 rehabilitation protocol, we have instructed our patient to stack cups using a pillow as an unstable surface. The patient will single leg balance on top of the pillow, perform an RDL, which includes keeping the balance leg straight, flexing at the hip, bending hip, and stacking our pyramid of cups using a 4 base, then 3, then 2, then 1. After the patient completes the pyramid, they will then pick it all up individually, one by one, until they have all the 10 cups in their hand again. As a clinician, you want to be aware that they are returning to the starting position after each cup placed. Then you can also instruct them to not flex too much at the spine. Try to keep the spine in a straight and neutral position the entire time. Bend more at the hip. Do not flex the knee as much, so that way, in hopes of them lowering themselves, make sure there's more flexion at the hip instead of just bending at the knee. This can be progressed by adding a weighted vest, incorporating a more unstable surface, or by increasing the distance between the patient. For this exercise of the phase 3 rehabilitation process, we will have the patient perform a step up exercise We'll have the patient start off about a foot and a half away from the step, placing their injured extremity, in this instance, the right ankle, first on the step, then activate the quadriceps and the glutes and various muscles in the ankles to stabilize in order to shift their weight on top of the step. During this exercise, as a clinician, you want to view for any compensation in the patient by seeing if there is any hip drop, if the opposite hip, which will be caused by a weak glute min. You also want to be aware of any shifting due to compensation. You always want to have the patient face up, torso up, and no flexion at the hip joint. All right. For this, you can progress it by incorporating a knee drive of the opposite extremity as performed here by our patient. From there, you can perform a calf raise of the injured extremity during the knee drive as performed here by our patient. Since we are at home and we had to improvise, you can also progress this by adding a resistance by holding 2 gallons filled with water as you perform this exercise. And if you are lucky enough to have some dumbbells or a weighted vest or anything, you can also apply that for resistance. For this exercise of the Phase 4 rehabilitation program, we will have the patient perform what I call a resisted go and catch. All right, we have placed a TheraBand around the patient's waist and then used resistance cords to attach the patient to the fence. The patient will sprint away from the fence towards the ball thrower, balance themselves on one leg and catch the ball. They will balance themselves on the injured extremity while catching the ball, like so. All right. With this exercise, the patient is looking to develop sprint speed with the resistance cords, develop balance while single leg balancing, and coordination while being single leg balance and catching a football. This exercise can be progressed by adding more resistance cords between the fence and the patient, and or adding an unstable surface for the patient to balance on while they're in that single leg balancing. In the clinic, I would use a Bosu ball, but here we have used a couple of folded up towels that the patient will now balance on, then sprint and catch a football while balancing on one leg. Nice. For this exercise of the Phase 4 rehabilitation program, we will have our athlete perform a positional metabolic workout. This exercise will incorporate stresses placed on the ankle that will be similar to that seen in competition based on the athlete's position and or sport. This will also increase a cardiovascular endurance in the patient based on their position and or sport. All right, for this exercise, we will have them perform various amount of drills and exercises that would be seen during a normal defensive drive, okay, such as side shuffling to the right, turning and going and grabbing the receiver, okay, all right, side shuffling to the left, blitzing, and backpedaling and going and covering the receiver. All these are normally seen in a defensive drive. During this exercise, you want to look for any compensation in limping or turning and going. And you also want to be able to progress this exercise by limiting the amount of breaks in between, shortening the time of breaks in between, and or having the patient do the drills quicker and more effectively.